Our next guest is Dr. Christine Bowen, who is helping people manage their health through the specific carbohydrate diet so they aren't alone. Dr. Bowen is a doctor of naturopathy practicing in Washington State. She's used the SCD to manage her own health and that of her patients for over 13 years. She earned a Bachelor of Science in Zoology at the University of Washington and completed her doctorate in naturopathic medicine in 2005 at Bastyr University. And she's the founder of Inside Health Institute, a nonprofit dedicated to integrating holistic approaches into healthcare, especially for underserved populations. So 2 years ago, Dr. Bowen reached out to Kirkton Press about her plans to create an SCD practitioner's manual to provide consistency for doctors and others using the SCD for their patients. And I was so impressed by her knowledge, her scientific lab-based approach, and her commitment to the diet and to her patients. Several months later, our family sought Dr. Bowen's help, and we will forever be indebted. She helped our daughter with very challenging intestinal problems when no one else could. And we turned to her subsequently when other members of our family needed help. Let me just say that she is an incredible professional to have in your court. Her compassion, her knowledge, and her thoroughness are truly unparalleled, and I'm honored to present her.
Thank you so much, Judy. I wish I could hug you in person. Love you so much. Wow. Okay, I'm gonna get myself together and I'm gonna present. What an honor to be here and to be part of this community. There were very few people in my community who knew about SCD, and definitely nobody in my profession was talking about it when I found it in 2008. And it was like heaven sent for me personally. So I can't wait to tell you a little bit more about my personal journey, and then also some of the ways that I've used SCD as well as other treatments to help people who have digestive health conditions, and then also some underlying hidden issues that might be going on that co-occur that make recovering from inflammatory bowel disease and other conditions a little bit more difficult. So, all right, without further ado, I'm just going to go ahead and dive in. So to tell you a little bit about myself, I originally had a diagnosis of IBS starting from the time that I was a teenager, and then just kind of suffered in silence. I did seek help at least a few times, going to traditional gastroenterologists, going to rheumatologists for my joint pain, and always came away disappointed and felt like they were saying, you're young and healthy, go live your life. But the reality for me was that I was having daily bowel movements up to 9 or 10 times a day, extraordinarily painful cramping, many bowel accidents, which are just humiliating. Being a young, otherwise healthy woman going through school to become a naturopathic doctor, I was very inspired to try to figure out how to help myself so that I could help other people. And so I even sought help from my colleagues and tried every probiotic and digestive enzyme and allergy elimination diet out there, but did not find my healing there. It wasn't until I was a few years out of school that I ended up just randomly coming across the specific carbohydrate diet. And basically, when somebody introduced the specific carbohydrate diet to me, I thought, this sounds like a great plan for me to help my patients with. And so I learned how to do the specific carbohydrate diet, how to follow it, got the book, Breaking the Vicious Cycle, learned how to follow it just to be able to help others. But I had no confidence that it would help me because nothing else had. And so when, 3 days into the diet, I had my first formed bowel movement in my entire adult life, I was extraordinarily pleased, and I never looked back. I felt like this was a diet that could be helpful to people who were in the category of people like myself who felt like they were unhelpable. So my personal experience was that I had IBS. There was a likelihood that I had autoimmune diseases early on, but I actually know that that's positive now. Later on, found out that I had SIBO and then also dysbiosis. These two go hand in hand. I had really bad reflux for many, many years as well, co-occurring anxiety, weight gain, and then whenever something is not working or I feel my symptoms sliding, I still will default back to SCD as my safe place. So once I learned how to use this specific carbohydrate diet for myself, I started to apply it for my patients with IBD, IBS, autoimmune diseases, some patients with SIBO, dysbiosis, any of those conditions, even things like diabetes and skin conditions. Once we start working on the microbiome or the gut health, then these other conditions can really benefit or improve. And so as I've spent, the last 12 to 13 years focusing on SCD, I also have made connections with local providers. So Seattle Children's Hospital is where a lot of the research has been coming out on SCD. And I was really excited to be part of that conversation when Seattle Children's was looking at adopting or standardizing SCD for use with their patients. I have made it my goal to really make sure that other providers are trained. And so as Judy was saying, I really want to see more providers on the front lines helping people so that people don't feel like they need to navigate this on their own. So speaking opportunities and authorship comes along with training other providers. And then recently I was a podcast guest on Lee Bernstein's podcast, which was a fabulous experience. So there we are at the Seattle Children's Hospital Nutrition Symposium. And so you may recognize some of these faces. It's kind of like a who's who of SCD. There's Lucy and Ramon. There are a few other faces there that you should recognize. And then Dr. David Suskind back there with me. So that was just a wonderful chance to be able to hear some of the early research that was being done on SCD. And then also to know that this was part of the early inspiration of Dr. Suskind going forward and really starting to promote and use SCD in clinical practice as first-line therapy. So most of you are probably familiar with the specific carbohydrate diet. Instead of relying on my quick little overview, you definitely can look at the more comprehensive list of what's included or what's not included at breakingtheviciouscycle.info. But in general, any of the meats or proteins that don't have any additives or other ingredients, those would be safe on the diet. Certain legumes prepared according to SCD rules. Dairy that is lactose-free, such as butter, ghee, some aged cheeses, and a 24-hour yogurt. And then things like vegetables that are fresh, frozen, or raw, they don't encourage canned. And then also same with fruit, so fresh, frozen, raw, or dried fruit with no sugar added. And then most nuts and nut flours, especially when they don't have other ingredients added to them. And then things like nut milks oftentimes will have to be homemade unless you can find them without the disallowed ingredients. So beverages as well, weekend plain tea and coffee and juices with no additives or sugars, and then condiments and oils, such as most clean vegetable oils, mustard that has only legal ingredients, and then cider and white vinegar. And then honey is our main sweetener. And then I find in practice that texture and the fiber content of foods may need to be modified depending on individual tolerance. So we definitely can combine SCD with more of a low residue diet if somebody is in flare and they really need to modify that texture. So originally, it was 3 days into diet. I had the first, I called it a hallelujah poop. I'm sure that some of you have had this experience where after so many years of really abnormal bowel habits, that suddenly something changes. And so I had that first hallelujah poop 3 days in, and I had normal bowel movements for many years. So it was, I believe, about 5 years into SCD that I still was doing very, very well. And then all of a sudden it felt like my symptoms were starting to slide again. And I was noticing that I was having daily diarrhea and urgency and bowel accidents, which is horrible when you're a provider trying to see people, with confidence that you're still running off to the bathroom. So something had changed with my health, and I didn't really know what had changed. It's not until a couple of years after that started happening that I linked it all back to food poisoning, and that I had 2 bouts of food poisoning very close together, and a third one that had happened sometime in the past. And so now we understand that this actually can create or set the stage for a condition called post-infectious IBS. And so when this happens, something can get damaged in your small bowel, and it's actually called the motor complexes, or the MMC, the migrating motor complexes, can be injured by these pathogens that create foodborne illness. And then those don't work as well. And then it can create this condition called SIBO, which stands for small intestine bacterial overgrowth. And this is a condition where the bugs that are normally present in the large intestine start backflowing into the small intestine. When they backflow into the small intestine, they start creating fermentation, where those bugs are eating the food that's meant for you. So once those bugs start overgrowing, then it starts creating this fermentation. Fermentation in turn can create things like gas and bloating, diarrhea, constipation, reflux. All of those things can be aggravated by SIBO. So I didn't really get testing or treatment for SIBO for another 3 years. So it wasn't until a couple of years ago that I even really started getting intervention for this. So I just would default back to the specific carbohydrate diet and make modifications, changing my diet, taking foods out, doing food allergy panels. And so some of those things helped to improve symptoms. But it wasn't until I really got tested for and treated for SIBO that my symptoms really improved, and now I'm back to normal. Thank goodness. I also was having increasing autoimmune disease symptoms. So hand pain, hip pain, just general joint pain, muscle aches and pains. And then recognizing that there were these certain foods that I was really starting to react to more and more. And so since then, we understand that I have 2 types of autoimmune disease that make it harder for me to eat a full SCD diet without my joints flaring. So I look forward to the day that full SCD will be back on board. So when I see patients, oftentimes I see patients who have been to, 5 or even 10 other providers. And these are the top 6 categories of some of the top misconditions. And so when I see these patients, I normally notice that these, the tests have not been done, or deeper workup has not been done. If somebody is diagnosed with IBS, or somebody is diagnosed with inflammatory bowel disease, the providers generally look at you as if anything that's going on with your health is due to just that IBD or IBS. But they're not really digging any deeper. And so what I find is that the answer is typically that there are more than one thing going on for a lot of people. And so when there's more than one thing, it's stacked on top of the other conditions, and it still could be interplaying with the other existing conditions. But once these layers are identified and peeled off, tested for and then treated, then we find that it's more likely for somebody to get fully better, or at least have marked improvement in their condition. So these are some of the top conditions that I find that other providers will miss. And these are typically the things that I start with when we're testing. So I still will monitor things like inflammatory bowel disease markers, or I still will monitor IBS symptoms, but I'm always asking the question, why? So why is this happening? And then are there other layers to it? So we'll go into each of the categories. So other autoimmune diseases, SIBO or post-infectious IBS, there's a lot of overlap with these 2 things. Celiac disease or other related food reactions. So celiac is true gluten allergy. often down to the molecule, versus other food reactions may be more like sensitivities. We'll dig a little bit into that. And then for women and also for men, there may be urinary tract causes or, symptoms that are in the abdomen that can mimic some of the abdominal symptoms associated with bowel disease. So gynecological, I see on the forums that there are a lot of people posting, and saying, well, actually, it was that I had these ovarian cysts and, I didn't respond to SCD because it was something else. But there's a lot of self-diagnosis, especially with IBS. So people just self-diagnose with IBS based off of symptoms that they find on the internet. But what if it's, ovarian cysts? What if it's uterine fibroids? What if it's surgical adhesions or other things that could go on that may be unaddressed or underaddressed? Chronic infections. And so chronic infections can include things like human herpes virus, infections like Epstein-Barr virus, cytomegalovirus, and then it also can include things like Lyme disease, or even infections of the bowel that have not been identified. So if you haven't had a 3-day stool test, you might be harboring an infection that is making it harder for you to recover or become asymptomatic. Other things like environmental toxins or exposures, those are definitely things that can play a role in making it harder for you to recover. So I would say that a lot of these would be not just missed conditions, but common causes of roadblocks in healing. So let's dig a little bit into each of those categories. And so when we look at other autoimmune diseases, many of these autoimmune diseases will have a digestive component. So it's easy to see how something like this might be missed. So if somebody is having diarrhea and they have a known diagnosis of IBS or IBD, could it potentially be something like Graves' disease co-occurring? If somebody has weight loss is common with Graves' disease. So when you look at each of these autoimmune diseases, first I would check a few of the symptoms and see if something might match up with what you've been feeling. And then when it comes time to have your next blood test done, then you might be asking your providers to add on some of these things. Like, oh, I've been noticing that I have a lot of hair loss lately and fatigue, maybe swelling in the front of my neck over the area of the thyroid. Maybe I'm having some depression or potentially constipation or, diarrhea down here. So Hashimoto's is autoimmune disease of the thyroid. So it's your immune system attacking your thyroid. Same with Graves' disease, autoimmune attack on the thyroid. So the thyroid controls metabolism, and this is definitely, it can put a wrench in your healing. So when we look at Hashimoto's, it has this initial component where it looks like you're having hyperthyroid, which is too high of functioning thyroid. It can create things like racing heart, anxiety, diarrhea, fatigue, weight loss, hair loss. But then later on, after the immune system has been attacking the thyroid for a while, it will normally fall into hypothyroid, which is low functioning thyroid. So Hashimoto's is something that you would test for, and these are the main two antibodies. So oftentimes when we go to our provider, they'll just order a TSH, which is just thyroid stimulating hormone. That's only the tiniest fraction of the information that I need to be able to rule out these other conditions that could influence how the thyroid is functioning. You can have a totally normal TSH and still have either of these autoimmune diseases. So check out the symptoms for any one of these autoimmune diseases and just see, like, have I had these conditions ruled out? And then if you have a provider that you're able to negotiate with to say, hey, can we start doing some of these labs just to rule out some of these other conditions? All right, lupus. So lupus can have overlapping symptoms as well with inflammatory bowel disease, and things like pain in the joints or skin rashes or inflammation. It also can come along with other damage to organ systems. And then one of the basic ways to start ruling out things like lupus and some of these other autoimmune diseases that we're going to talk about is to get a test called an ANA, and that's an anti-nuclear antibody. And I always ask for it with a reflex to type, titer, and pattern. that gives us the most information, so that if it's positive, then it's going to go ahead and give you a whole list of the potential tissue types that your immune system might be attacking. Then that can help you to get more detail on what other types of things might be going on. So when we look at bowel disease, any type of bowel disease, even IBS as well as IBD, the major part of your immune system is in your bowel. And so if that is compromised, then it's common for the door to open to autoimmune disease, and other autoimmune diseases may start to try to pile in. And so it's good to be able to know the lay of the land. Who's there? What's there? How do I address it? So definitely asking other providers to do some of these extra tests. For lupus, sometimes it can present just as skin rashes, and so they call that cutaneous lupus. So scleroderma is where things start getting hard and stiff. And so it can create hardening or stiffening of the skin and connective tissue. So that includes the connective tissue in the intestine. So you can see again how there's so much overlap with these things. Many of these conditions have joint pain. So is that extraintestinal manifestations of bowel disease, or is the joint pain due to something else? So it's really important to do these tests to tease it apart. So I've had several patients with inflammatory bowel disease who also have co-occurring CREST syndrome. So CREST is actually an acronym, and it stands for calcifications. So this is where you might have little calcifications on your finger pads. And then also Raynaud's, which is where your fingers may be painful when it's cold. The color might change on your fingers or your toes. Esophagitis just looks like really bad reflux. And then things like sclerodactyly. So sclerodactyly is hardening of your fingers. So you might find that they're a little bit rigid or hard. And then broken blood vessels. This is the T in CREST, and it's telangiectasia. So it's basically just little broken blood vessels. And oftentimes it won't look like much to people, but if you put all of these things together, then you're like, okay, CREST, it is. So this can be basically a low-grade version of something like scleroderma. And so again, that diagnosis, or at least trying to rule it out, would be doing that ANA with reflex to type, titer, and pattern. All right. So other autoimmune diseases, so rheumatoid arthritis, yes, that totally mirrors inflammatory bowel disease extraintestinal manifestations. So it's really important to make sure, is this extraintestinal manifestations, or is this rheumatoid arthritis? It's important to know, even though your GI or your rheumatologist may treat it the same, there may need to be some modifications within your treatment plan to address this piece. So if you have hand inflammation or knee inflammation or other joints that are inflamed, then oftentimes they'll do x-rays to see if there's inflammatory changes in those joints. These are blood markers, the rheumatoid factor and anti-CCP. And then psoriatic arthritis. So if you have things that look like rheumatoid arthritis, and then you also have psoriasis, then it might actually be psoriatic arthritis, which ends up being really hard to detect. Sometimes it won't have really straightforward, positive rheumatoid factor or anti-CCP. This is another marker for rheumatoid arthritis, but it's positive in some of these other conditions. So it's important to get the blood work, to look at the health history. If you have psoriasis, you might be seeing a dermatologist. You might actually need a rheumatologist if you're having both the joint pain and the psoriasis in order to get a diagnosis. So ankylosing spondylitis, this is something that I find a bit of, and in general, it affects men more than women. But I do find it quite a bit in women where it just has, it's like, oh, your low back pain is just because, you had a baby or something like that. But if you see this positive, there's an HLA-B27 marker. If you find that that is positive and they have all of these symptoms, and then you look at things like an X-ray or an MRI, then you're actually able to see, could they have this condition, ankylosing spondylitis, that creates this inflammation in the joints of the spine. It definitely is something that can be treated and addressed. And, there are a lot of things that need to be done as far as PT and other interventions to help people stay mobile with ankylosing spondylitis, but it's just important to know. And then with other autoimmune testing, so in general, when people they come to me with inflammatory bowel disease diagnosis, I still am doing these two tests, the ANCA and ASCA. And so these, there's another one actually that's not included here called SACER, which is anti-Saccharomyces cerevisiae antibodies. And those are ones that I do in addition to ESR and CRP. So these are other inflammatory markers, and they can be general body inflammatory markers. But if people are coming to me for the first time, then they're probably going to get a really thorough blood level workup or blood labs workup to be able to make sure that we know exactly what we're looking at. Is it just IBD, or are there other things going on? Also these ones, so Sjogren's, if you are dry, if you're so dry, everything's dry mouth, dry eyes, dry intestinal secretions, dry skin, dry vaginal tissues, constipation, and then oftentimes people will be seen by their eye doctor and they'll be told that they have chronic dry eye. Well, could it be Sjogren's? This means that all of your bowel secretions are also very dry. So if somebody is dealing with constipation instead of things that might be expected like diarrhea, then could there be something like Sjogren's syndrome going on? So again, you do that blood level for ANA with the reflex to type, titer, and pattern to be able to get the true diagnosis. And then sarcoidosis is another one that's really hard to diagnose. You need a chest x-ray to look for these granulomas in the lungs. But this also can present with gut symptoms. So if somebody has a dry cough, shortness of breath, and some gut symptoms, it might be good to rule out things like sarcoidosis. And then this is mixed connective tissue disorder or disease and undifferentiated mixed connective tissue disease. And so this is where we think that something is there, but it's not totally testing clearly like it's something, and we think that it has to do with connective tissue. So oftentimes it's the joint pain or muscle pain, but without clear labs that tell us it's something else. All right, the next condition that I find is co-occurring with inflammatory bowel disease. Actually, some of my colleagues are theorizing that many of the IBD flares may be due to things like post-infectious IBS or SIBO. And so then if these conditions are treated, then does it take you back to just having, the standard IBD without having a layer of something else going on that is creating problems? So let's say you went on a cruise, or let's say you traveled to India and you got really sick after that and you never recovered from it. Those are the types of cases that I really like to hear the history. So if you haven't shared already with your providers that you got food poisoning while you were in India and that was part of the provoking condition, or part of the beginning of having disease process, then it's important to rule these things out. So for ruling out small intestinal bacterial overgrowth, you definitely want to do either the lactulose or glucose 3-hour breath test to rule this out. So these organisms are overgrowing in your small intestine. They eat all of your food, they eat your food and then they ferment it. And then their waste product is either methane or hydrogen sulfide gas. Those gases are then absorbed across the bowel into the bloodstream, and then you breathe them out. So that's why it's a breath test, to be able to measure how much or what type of these organisms are in your gut. So right now you can test only for hydrogen or methane. I prefer the lactulose breath test. That's by prescription. Glucose is not by prescription, so patients can order it, but glucose is absorbed really early in the bowel. So it's hard to be able to figure out what the state of health is like in the entire small intestine when it's absorbed at the very first part of the small intestine. There is a new test that's coming out soon that will measure all 3 gases, but that's not quite available for the public. And then lactulose is by prescription. post-infectious IBS, a diagnosis of post-infectious IBS comes from just, did I travel somewhere or did I eat something that made me sick? And it can be from parasitic infections, protozoal infections, viruses, or bacteria. Any of those things could create that foodborne illness or infectious gastroenteritis. And so if you had it in the past and then it changed your bowel symptoms going forward, then it's important to just remember that this is part of your health history when you're sharing it with people. There have been studies that have shown that even as long as 25 years after having the original foodborne illness or gastroenteritis, that people still can develop new onset post-infectious IBS or SIBO. There is a blood test testing for antibodies to see if there's been the damage to the small intestine that can create that fermentation and the overgrowth of those bacteria. If you're getting an X-ray, sometimes people will get an X-ray in the emergency room because they're having abdominal pain. It's one of the things that they might do if they're trying to save money. So sometimes you'll see excessive bowel gas in those X-rays. So sometimes you'll also see a lot of retained stool. So those two things might actually be a sign that you have SIBO with chronic constipation, or at least with excessive gas. One of the things I want to say about SIBO is that SIBO oftentimes will be recognized, or like who should be tested. Typically, it's the person who feels like their gut is fairly flat or feels okay earlier in the day, but as they eat and as the day goes on, their bowel gets more and more hyperinflated to where at the end of the day, they might look or feel like they're 9 months pregnant. And so that is definitely somebody who I would want to have tested for SIBO. Things like a lot of burping too. That's something that I would want to test that patient for SIBO. Things like, new onset reflux where you're getting partially digested food up into your mouth, like those people I definitely would want to test for SIBO as well. So celiac disease. So you can, if a family member of yours has celiac disease, you definitely should get tested. When people get tested for celiac disease, typically the only one that will be done by a primary care or even sometimes a GI will be this one, the tissue transglutaminase IgA. They'll also maybe test the total IgA to make sure that your immune system is making enough of this type of immune system marker to measure this one. But this is really a more comprehensive panel. It's not even the most comprehensive celiac panel that's out there. Some people who are not eating gluten then may have to default to a different type of testing. So to get a celiac blood work panel done, you need to be eating gluten. So if you're not actively eating gluten, as many of us are not, and we haven't been for years and years on this specific carbohydrate diet, we may need to have this genetic panel done. And so things like HLA DQ2 and DQ8, those are some of the markers that we can check for if you happen to be gluten-free. And then this can tell you a little bit about whether or not you have a genetic risk for developing celiac disease at some time. And so it will give you a percentage of probability or like a ratio of odds that you have celiac disease, but it can be very, very informative. So 1 in 4 close relatives will have celiac disease, and then autoimmune disease. Celiac disease is an autoimmune disease that inflames and erodes the lining of the intestine. So those little villi or those little fingers can get chopped off by the immune system. And so that definitely can create a lot of problems with absorption of nutrients, malabsorption, and then you might have symptoms like generalized inflammation, other bowel symptoms, and also canker sores. All right. Leaky gut syndrome is something that a lot of people have been talking about more recently. It's like a catchphrase or a buzz phrase, but naturopathic doctors have been talking about leaky gut syndrome easily since the 1970s. So we didn't necessarily have this science to be able to really understand exactly why it happened, but we knew that when there was a problem in the bowel, that if that was not addressed, then all of these other things could crop up, including skin rashes, including other bowel symptoms, including joint pain. So we knew that if there was an issue with the gut that was unaddressed, then suddenly you would get all of these other things, all this cascade of other things cropping up. And so this is where we want to make sure that if somebody has leaky gut syndrome, that we identify why it's happening, help to address that, and then helping to address that will help their immune system to recover, their gut immune system to heal back up. And then we have nice immune defenses and less of those symptoms that develop from having leaky gut syndrome. So allergies. So we talked about celiac disease. That is a true allergy to gluten down to the molecule. Something like a food sensitivity or a food intolerance typically is something that you might test with different blood work. And so that's typically what we call an IgG, or a delayed immune system reaction, versus something like a true allergy. It's typically detected by IgE. So true allergies may be things like even a nut allergy. And we know that that can be deadly serious. So we want to make sure that if people have true allergies to things, that those are being avoided 100%. Sometimes you can detect allergies, true allergies, with some of these other markers, but typically they consider IgE to be that true allergy marker, and then these other ones being more sensitivity markers. And then these are the most common food sensitivities. So eggs, dairy, nuts, chocolate, shellfish, corn, strawberries, and wheat or gluten. So many of these things are not allowed on SCD, but some still are. So there might still be, food sensitivities that, especially if SCD hasn't worked quite as well for you as it's worked for all the other people, and you're like, what's going on? Could it be that you still have a few of these food allergies or sensitivities that just haven't been addressed yet? And then we talked about gynecological, urinary, or pelvic conditions. So things like ovarian cysts, uterine problems, including endometriosis, fibroids, or like benign tumor growth. But it could also be things like cancer. Like, I don't typically like to scare people and say, you need to rule out cancer, but it is always something that I'm still, as much as we possibly can, looking to make sure that we're not missing things like this. Because if you do catch things like cancer, typically the outcome is going to be so much better if you find it now and address it now, versus waiting and then finding it when it may be too late to do anything about it. So I don't like fear-based medicine, but I like us all to be very aware of, what could possibly be going on, especially for women. If their symptoms are cyclical, then you might be thinking, oh, it could have something to do with my uterus or ovaries. And so for women, pelvic and transvaginal ultrasound to be able to look at the ovaries and the uterus. Sometimes they don't need the transvaginal, just the pelvic. Things like kidney stones can create symptoms like you're having bowel problems or urinary tract infections. Found that many people will have urinary tract infections for a long time, and it's chronic, and they just haven't actually recognized that their sweating is your body going through fever and chills. So it's important to get urinalysis with your annual blood work. All right, abdominal ultrasounds can also tell you, do I have liver or gallbladder issues that are unaddressed? You also can see your pancreas or part of the pancreas, adrenal glands, and spleen in this type of ultrasound. And then also that x-ray of the ultrasound. So that could show you kidney stones, but then also that x-ray of the abdomen could also show you excessive bowel gas, which might point back to something like SIBO. These chronic infections are things that I do commonly find with my patients who have more complicated conditions. So where we think, okay, it's not just this one thing or this other thing, there's something else going on. So people who have hoarseness, sore throat, swollen glands, body pain, fatigue. So this was something that Lee and I talked really briefly about on her podcast. But when people have a diagnosis of fibromyalgia, typically I'm testing for Epstein-Barr virus and cytomegalovirus, and so often they are positive. They're positive for something called chronic mono or chronic EBV or chronic CMV, where 3 out of 4 of these markers is positive, or 1 or both of these are positive. If you see the IgMs being positive, then it means that it's actually a new infection or a current infection. When you see these 3 IgGs or this IgG, it means that it could be what we call a reactivated or chronic infection. So then treatments definitely need to be geared towards helping with viral conditions. So if you've had tick bites and you have some of these symptoms, then you should definitely be screened for Lyme disease. And it's common mostly in the Great Lakes and northeastern regions of the United States, but other places in the world. All right, other chronic infections. We know that Jeffrey has talked about this one very openly in the past. So candidiasis, this is basically where you have yeast that overgrows. A lot of times people think that yeast is a bacteria or something that you need to take an antibiotic for. It actually, taking an antibiotic could actually make yeast that much worse, because yeast will actually be kept in check by our healthy bacteria in our intestines. And so candidiasis can be this overgrowth of yeast. Yeast likes to bore holes in the lining of the gut. It anchors itself, it grows root systems, and then it blebs off little babies, and it keeps on reimplanting itself. So if you took an antibiotic and you got much worse towards the end of it, you might have created things like dysbiosis, or that imbalance of good to bad bacteria in your gut, or you might now have an overgrowth of yeast. Oftentimes women will recognize it quickly when they get vaginal, vaginitis, vaginal candida, but many other symptoms can present, including things like skin rashes, joint pain, fatigue, gas and bloating. There are a lot of other things that can show up when candida is present. A lot of people complain of foggy brain. And then also we talked about ruling out any of these other pathogens or organisms in the gut that might be creating problems. So any of these can create problems and can still be co-occurring, even if it's like a low-grade chronic infection. So it's important to do things like a 3-day stool test to rule those out. Environmental and toxin exposure. So this is where, so if you've been exposed to mold or other chemicals, or you've lived in a mold sick building, a water damaged building, you've worked in water damaged environments, then it's important to get mold and mycotoxins ruled out, because even if you're no longer in that environment, those mold toxins can actually stay in your body until they're identified, and then a program is embarked on to help to release them. So it's important to make sure that you're ruling this out. And oftentimes people who have really chronic sinus issues and their food allergies have already been, ruled out, or things like that, making sure that there any other underlying causes of sinus problems has been ruled out, but they still have these symptoms. And then we start asking about the history of where they've lived or worked, and if they've ever lived in water damaged places, then we're definitely going to do a urine mycotoxin test. And then if it's positive, we have to have a remediation plan for pulling those mycotoxins out of people's bodies, but then also encouraging them at that time to have their environment tested and inspected. Heavy metals, so you can do blood, urine, or hair analysis to rule out some of these heavy metals. And then also things like other environmental toxins, you can do urine and blood detection to be able to check for things like plastics or hydrocarbons. There are so many other environmental chemicals. I feel like our world has definitely gotten a bit more toxic. And then those chemical compounds can disrupt various parts of our normally healthy functioning systems. So it can disrupt the immune system or the nervous system or endocrine system, which balances out hormones and blood sugar and all of that. So I love all of these tests, including, as Dr. Kiefer had mentioned, calprotectin. So calprotectin, fecal calprotectin, and lactoferrin, I do them both. I know that lactoferrin has fallen out of fashion, but sometimes I'll see that a calprotectin is completely normal, but a lactoferrin is very elevated. Also things like mycology or yeast or fungal culture in the stool. And then if the test is a 3-day stool test, you have better likelihood of detecting any of those parasites or any of those microbes there that might be missed with just a 1-day stool test. Zonulin is a marker for leaky gut syndrome that is also in stool tests. And then we talked about breath tests for SIBO, but also for H. pylori, lactose intolerance, and fructose malabsorption. And then this is one of my basic panels, but it definitely would say that it can extend a little bit further than that, including that Saccharomyces cerevisiae antibody that is not there. So, oh, actually, that is anti-Saccharomyces cerevisiae antibody is ASCA, sorry, and then ANCA. So ANCA can be positive more often with ulcerative colitis, and then ASCA can be positive more often with Crohn's disease, but it's not necessarily, always that way. And then urine markers. So urinalysis, making sure that they reflex to culture just in case they find some organisms, then we'll be able to find out who's there. Mycotoxins in the urine, and then organic acids testing. So if you're in an unlicensed state or you don't have access to somebody like me, then doing something like an organic acids test can sometimes pick up which types of organisms might be there or other conditions that need to be addressed. All right, this is my general approach with patients, is just to make sure that I remain curious and then do deeper testing to reveal underlying causes of health problems. I love getting baseline labs so that we have a starting place for when we start working together, and then periodic labs to assess change over time. So when people were asking about working with resistant providers, definitely having things like that baseline testing and then being able to assess changes over time periodically can really help to give you that information to share with your provider to see, SCD or the therapies that I'm trying are moving things in the right direction. So, please don't worry about biologics at this time or having that conversation, because the proof is that my system is continuing to heal. So it's really nice to have those labs. And then using diet therapy whenever possible. And then always striving for as expanded of a diet as possible as well. And then I always have a partnership with my patients. Ollie or Jeffrey, can you tell me how much time I have left?
Keep going.
Okay.
You're doing just great. Thank you.
Okay, great. I just wanted to time check. So my favorite treatments, I have so many treatments in my toolbox. When you're talking about a conventional provider who really only has, surgery or some of the more common medications as their toolbox, it's just a limit to their toolbox. It's a limit to their training. So when we look at myself, I don't have surgical interventions in my toolbox. Instead, what I have is diet therapy. I have herbal medicine. I have some of these other holistic interventions. That's my toolbox. Things like counseling with my patients. That's in my toolbox too. So my toolbox is just different than other providers. And so even different within the providers in my naturopathic community, where naturopathic doctors may have the same training, but they may use totally different treatments depending on where they're practicing or what their background is. So one treatment that I do use quite a bit in helping patients with autoimmune disease is low-dose naltrexone. And so there are more positive studies out there than there were when I first started using this for my patients back in 2008. Low-dose naltrexone binds receptors in the brain, and then it upregulates something called enkephalins, and those enkephalins help to modulate the immune system. So this means trying to correct the dysfunction in the immune system instead of suppressing the immune system or stimulating the immune system. It's an immune system modulator. So there are some studies, and there's a link to the study in the reference section. Also boswellia. So boswellia has some good research out there. This is Indian frankincense. A lot of people go straight for turmeric or curcumin. When we're looking at bowel disease, it's actually better to use turmeric that is not enhanced for systemic absorption. Curcumin is just an extracted piece of the turmeric. And so when we look at turmeric itself, using it as a whole herb, and then maybe, if it's a whole herb and encapsulated, that may have more anti-inflammatory action for the bowel, versus when you use the curcumin extract or something that has like black pepper in it or other things that help it to be systemically absorbed. That would be more useful for things like the joint pain. So if you have systemic symptoms, kind of outside of your bowel symptoms, then things like curcumin would be better than maybe turmeric. But if it's bowel related healing that you're looking at or trying to calm the inflammation, then you want to use the standard turmeric. Other holistic approaches. So glutamine is, it helps with coating, soothing, and healing mucous membrane lining in the entire bowel. So this sounds pretty useful. One of the things you want to make sure is that the glutamine is from a source that is not off of your diet plan. So sometimes it will be corn derived, and people might not respond as well to that. A natural source of glutamine is sauerkraut. So if you're in a position to tolerate some of these fermented foods, and you can have sauerkraut, that's a natural source of glutamine. Also, we had talked about B vitamins and iron briefly as being some of the things that people are commonly deficient in. And so when we look at bowel disease, or you might be missing portions of your intestine due to surgeries, we need to get creative in how we're administering some of these vitamins and minerals. So things like a transdermal patch or intramuscular injections or IV therapy, those are some of the other ways, especially if oral doesn't seem like it's enough to be able to help your B vitamin levels improve. So you can try oral if you can find a clean source, and it's the first place to start. But sometimes I'll have people do, skin patches in the beginning, just to make sure that you're not aggravating or adding another thing into your bowel that it might not tolerate. And then iron, we know that irritated bowels do not tolerate oral iron in general. It's normally something that your GI or your hematologist will offer first. They'll say, take oral iron. And I know from history that inflamed or irritated bowels do not like oral iron. And so people may need IV therapy or intramuscular injections, but there are also transdermal patches. So that's across the skin, transdermal, that you can also get patches or things like that to give you different ways of getting iron into your system. But my favorite iron resource is liver. So many of my patients don't like that recommendation, but we definitely have been able to recover people's anemia through liver alone when we're not able to deliver some of the other types. And then when you have iron, co-administration of things like vitamin C, or combining your iron-rich foods with citrus or with vinegar, that can help with the absorption of the iron. And then zinc carnosine is a type of zinc that also helps with mucosal repair. So there actually have been some research studies on enemas with zinc carnosine in patients with ulcerative colitis. And I think I also have that reference to the study down in my notes. And then other things that you might try, fish oil definitely is an anti-inflammatory. It's known for its anti-inflammatory action. You definitely want to make sure that you have as clean of a product as possible with allowable ingredients. But in general, I feel like also with mood. So I think of fish oil with mood, memory, skin, gut. So there are so many different places that we want to use fish oil. And so we think of our brain being predominantly fat. So a little bit of extra omega-3 is typically a good choice for people who have inflammation, or even things like anxiety or depression. And then cannabidiol is anti-prokinetic. So if somebody is already constipated, then this actually could exacerbate it. So it's important to know that, or it could make it worse. But it does have anti-inflammatory action. It's been hard to get human studies, but there are some human studies out there showing that it creates a decrease in pain, maybe a decrease in diarrhea because of the anti-prokinetic effect. It can help with things like nausea or possibly increasing appetite. And then we love vitamin D3, and it is a common deficiency with inflammatory bowel disease. Typically, I will dose vitamin D based off of people's levels and then also their ability to absorb it. So a lot of recommendations start at about 800 IUs, but vitamin D is something that you can get toxic in, so you can get too much of a good thing. So you just want to make sure that you're dosing off of your physician's recommendations, and it's vital for calcium absorption. We know that osteoporosis is very common for patients with IBD. So really that combination is excellent. And then types of calcium matter. There are certain types of calcium that may aggravate diarrhea versus ones that may make you more constipated. Absorption matters. And then co-administration with vitamin D can definitely enhance that absorption of calcium. So when SCD is not enough for some of my patients, as far as like dietary therapies go, then I may consider, so if somebody is in a flare and they're trying SCD intro or that very like starting plan, we might have to actually take a step back and do things like a liquid diet. I don't recommend that people do a liquid diet or an elemental diet without physician supervision, just for safety. You really want to make sure that you know what you're doing, making sure you're getting adequate nutrition so that you don't drive yourself into malnutrition. But things like bowel rest might be necessary if somebody is not doing well with food. So any food sometimes will aggravate. So then we take a step back and we do more of an elemental diet or powdered nutrition. There are a lot of different products on the market now. There are some studies coming out showing that there might be a whole food version of it where you puree it and do basically like shakes. I think that some of the research on that is coming out of Seattle Children's Hospital as well. So we might have to do that. If SCD doesn't seem like it's the perfect fit, it may still just need a couple of food modifications within it. And so things like doing a food allergy panel to make sure that you don't have to pull out. Maybe you have to pull out things like eggs or dairy, and maybe you only have to pull them out for a little while and then you can reintroduce them. It's just important to have this extra piece of information to guide you. And then when infections or overgrowth or things like that crop up, then obviously you need to test for them and then treat them. And then you may have to make even short-term dietary modifications with, SCD combined with other things. But again, only with provider guidance. So in general, having the broadest SCD diet, or sorry, the broadest SCD intervention is the absolute best, because they show that your microbiome diversity is that much better when you have a very rich diet. I just attended a conference where they said 30 vegetables a week will give the absolute best, most diverse microbiome. And so 30 vegetables a week, whether they're pureed and peeled and de-seeded, or whether they're whole and raw, if you're able to tolerate them, just make sure that you're getting the most varied diet. So we get stuck in ruts with SCD where we keep on doing the same thing. We have our favorites. It's really good to just remember that you need to rotate the foods within your diet to help with microbial diversity long term. And so I will conclude in just saying that if you or your provider need a second opinion on your case, then I am available for consulting work outside of Washington. But if you live in Washington State, I can offer full medical care via telemedicine as well. So this is my contact information. And I thank you so much for your attention. I know that was a lot of information. I hope that it was well conveyed.
Well, thank you, Dr. Bowen. That was a whole lot of useful information. I'm still absorbing it. I'm sure we all are. And we're glad this is going to be recorded and shared, because there's a lot of valuable insights. So thank you for that. Jeffrey's going to step in a moment to present some of the questions that have been streaming in. Everybody's been really engaged in the chat and sending questions and follow-ups. So just stand by for that. But before I hand it to Jeffrey, I do want to say that, Dr. Bowen, you presented a very nice background from your career and professional background, but not all naturopaths have such a deep level of training and emphasis on nutrition, which you do. And then you also bring in the personal and patient background that focusing on digestive and issues. So I think those two things have really helped us really get a deep dive on how you practice and how much emphasis you put on nutrition and diet intervention. So I'll pause right there, and Jeffrey, if you don't mind unmuting and jumping in with some questions. Thank you.
Do you want me to stop sharing my screen?
Yeah, you can stop your sharing, and then we'll your camera will take over.
Okay, thank you.
Thank you.
Thank you so much, Dr. Bowen. It was awesome. The response, it's so much to cover, and timing wasn't as important as hearing your passion for what you do. and to be able to share your personal success while you're, working, because it may not even be work for you, because it sounds like you're getting a lot of self-reward from this, helping others. And it truly is commending to be able to reach out and offer your expertise to the SCD community. So
It's my
I know,
pleasure.
it was a matter of timing, but I knew that eventually all this would happen. So I'm very excited. And, it was an awesome introduction by Judy, made me cry.
Yeah.
So,
Oh my gosh.
So thank you. There's a lot of responses, wonderful information. It was excellent. Thank you, Dr. Bowen. We have an appointment with you on November 4th. Thank you very much, Dr. Bowen. Very informative. How can I find a local naturopath that focuses on nutrition as much as you do? So one of the things that was not mentioned was Dr. Bowen has been grateful enough to share a list of resources that we will be making available for people, so that they have access to be able to find what their needs are. And if you want to offer anything more on that, that would be great.
Yeah, I just put together, kind of quickly threw together a handout that is a little bit, telling you what the difference is between a naturopath and naturopathic doctors, what sort of training you should be looking for when you're looking for a provider. There are global naturopathic doctors or something like that. We're called different things in different countries. A lot of resources for the US and Canada as well. So I'll hand off to Jeff, or the handout to Jeffrey, to share with you all, to make sure that if there's somebody that you can find. So one, you may find a naturopathic doctor, but you may not find a naturopathic doctor who really focuses as much on nutrition. So ask them questions about SCD. You might even ask them questions about other overlapping dietary therapies, and just see what their knowledge is like. Just make sure that you're interviewing them as much as you're being interviewed. It really is a mutual interview anytime you're working with people.
Thank you. Very much enjoyed this presentation. Thank you, Dr. Bowen. Excellent presentation. Thank you. I want to become one of you for Ireland. Tell me how. So we'll share some stuff. I have your information. Love this presentation. Thank you for informative, very engaging presentation. What do you mean by liver for your favorite iron supplement method? Did I mishear you, or were you talking about liver?
I was talking about liver. Yeah.
And a second question was similar, where it was, is taking liver capsules for patients the same as eating liver?
Capsules are such a small amount, even if it's dried out. I like people to make a more enthusiastic quantity of liver and have that in their diet. And so sometimes we'll grind it together with other meats to make meatballs, especially if you're trying to hide the flavor of liver for kids. Soaking it in lemon juice overnight can definitely help to reduce some of the gaminess. Plus, it helps with that vitamin C. So I made a lot of pate when my hair was falling out and I was super anemic. I was making a lot of liver pate that was delicious. And I ate it on cucumbers, and it was my new favorite food. But, it really can help with recovery of anemia instead of just going to iron infusions. Just know that we have a lot of iron-rich foods, as long as you still have the pieces of your bowel that can absorb it.
There was a couple of questions that dealt with associated costs. I'll put them all together, but one of them was, can you speak to the insurance covering these labs, if not associated costs? Give me a second. It was, if your insurance plan doesn't cover it, what is the most important test that you can ask your primary care doctor to do? They may not have to be, can't afford the private pay for someone of your expertise. How and what could we do for our own doctors that we're
So taking the list of the blood tests and taking the list of the stool tests and just saying, would you consider doing any of these? would you consider doing some of these? And so things like calprotectin, I would say, is one of the most important stool tests. But if you've never had a 3-day, rule out parasite stool test, oftentimes your provider would be like, oh yeah, we could do that. That seems like something that they might be willing to do to make sure that there's nothing co-occurring. I think that the high sensitivity C-reactive protein and erythrocyte sedimentation rate, that those are the two most common inflammatory markers that might be done. But that ANA with reflex, type, titer, and pattern, if you're curious about autoimmune disease or other autoimmune disease, then that ANA is really important. And I hardly ever see it done in primary care.
Along that same line, someone asked, at a previous SCD conference, which I believe was 2 years ago, we heard about the possibility of a home fecal calprotectin test being available. Are we any closer to that? And when can we perhaps expect something like that available, that we have a home kit?
Actually, many of these have home kit options. So if you're not working with a provider or you can't afford to, the home kits are pretty expensive as far as self-pay goes. Jeffrey, I think that you had posted some resources inside of our group in the past for self-order, self-pay. So if people don't have insurance, there are companies where patients can self-order, self-pay. And so I might not mention those specific companies here, but it's something that I can give information to Jeffrey so that he has information to share with the community. So if you don't have providers who are open to ordering these tests, then you can go around them. You can order them for yourself.
Let's see. Kidney stones. So we hear about kidney stones, and people are wondering, and there are secondary diseases of IBD with the kidney, the liver, could be thyroid, it could be adrenal gland, could be hormones. And recently there was actually a few men and women that were talking about the pelvic floor issues. So, I covered a lot, but but kidney stones. So there's, kidney stones. Is that something that people are like high oxalate or low oxalate, or they need to change their diet? And how do you do that?
Oh, if people have known stones, yeah. So you may have to pull in the extra layers of, following a slightly different dietary regimen. But then there can be supplements or nutrients that you can add to help your body excrete more enthusiastically so that you're not retaining it as a stone. But one of the most important things with kidney stones is hydration. So just reiterating, I think, Jeffrey, you posted recently about hydration. And so just remembering that water is really important.
Do you see a connection between the MTHFR mutations and heavy metal toxicity?
I'm not necessarily an MTHFR specialist, so I know that it definitely can create interference in being able to absorb or use certain types of B vitamins. So if those types of B vitamins are involved in detoxification pathways, then yeah.
What food sensitivity tests do you like? Some prefer IgG, but can reflect frequently eaten foods and not necessarily tied to actual symptoms. Others, like MRT, are cell-mediated, showing that the immune chemicals are actually released, but many holistic doctors do not prefer this. Neither of these address food intolerance issues, but I feel there is probably not just one test that covers all situations. Your thoughts, please. Thank you for a great presentation.
Thanks. So actually on one of my colleague chats just the other day, there was the question, which food sensitivity tests do you prefer? And there, everybody had a different answer, and there were just so many choices. For me, I tend to use one that's IgE and IgG4 combined. And so I believe it's an ELISA test. And so it's just I know some of my patients have done MRT. Some of them have done, other companies or other techniques, but I tend to stick with the one that I've been using since the beginning of my practice because, and I keep on coming back to it anytime I deviate and try these other labs, the one that I keep on coming back to. Can I say the company name or no?
Go ahead.
Meridian Valley Labs, and they're actually here in Seattle. And I think that they do direct consumer testing as well. So I believe that any of you as consumers can call them and order your own test. And I prefer the extended test, which is 190 foods and spices. And I think that it's under $400. So I would say for that quantity of information, it's a pretty competitive price. I know $400 is still a lot of money for many people, but for the information you get, and I just find it to be the most clinically useful information.
Such a wonderful presentation. Thank you from England. Thank you so much. I see a functional medicine doctor who has shared some of his information with me also. Thank you, Dr. Bowen. That was awesome. Do you recommend celery juice?
Somebody's been reading the medical medium. Like suddenly in my office, every single one of my patients started asking me about celery juice. I would say that the information is mixed about whether or not people are seeing, direct benefit from it. I don't necessarily know about studies. I do know that celery has nutrition in it and that it's a cooling food. So if somebody has inflammation, it might be helpful. So it was like suddenly the new buzz thing. So everybody was talking about it just in the last year. But not
I think he was on Dr. Oz too. But
oh, okay. Yeah, I'm like not necessarily as a core part of my treatment protocol, but normally patients have tried it on their own and they tell me afterwards.
Thank you, Dr. Bowen. Very enlightening. So happy to see you have been on a good path. When I found Dr. Bowen, I cried for our daughter. I knew we were in good hands. Love her. Do you recommend herbal tea?
Depends on the types and tolerance. It just depends. So each person's tolerance is going to be different. I do prefer herbal tea, even though my mug says coffee on it. There's no coffee in there. I'm a tea only girl because my guts prefer it. So if people are still having things like diarrhea, or reflux, I would definitely consider, second guess the relationship with coffee and try to see if they could switch over to herbal tea. Green tea does have some extra healing properties that other types of tea may not. Careful with the demulcent herbs or the herbs that get kind of slippery because those are not permitted on SCD.
My GI doctor told me to follow SCD, eliminate all acid reflux trigger foods, and to follow low FODMAP with SCD. They don't all agree on what's allowed. Help.
Yeah, so there's a resource called SIBOinfo.com. It's www.siboinfo.com. And that has the resource for SCD plus low FODMAP, and Monash University is really the final resource on what's low FODMAP. The thing to remember is if you're following SCD plus low FODMAP, that's supposed to be a very short-term treatment, not a long-term treatment. If you're following low FODMAP and it's working for you, it means that you have SIBO that needs to be tested for and treated. If you're following low FODMAP, you're just managing symptoms. So you need to get tested and treated if you have SIBO, and you should not stay on that limited of a diet for a long period of time.
It's interesting because it's always, if it doesn't work at this time, try it again later. But I think sometimes when you have a bad reaction the first time, you're kind of hesitant to try, and it might be a bad reaction again. But I can only share my personal experience on that is you just give it a try, because you don't want to limit yourselves too far or too long. So yeah,
it just leads to malnutrition really quickly because we already have a diet that has certain food groups excluded. If you start then dropping more and more and more things, then one, you're damaging your microbiome diversity, but then two, you're also risking malnutrition.
Would it be ever, would it ever be beneficial to add the elemental diet while on the SCD? For example, just as the last meal of the day to give the gut a rest?
I actually have done that with patients, especially patients who have trouble maintaining their weight. And so we've used it as a supplement because it's passively absorbed across the gut. So we're not trying to do like full bowel rest at that time, but instead just trying to give a little bit of supplemental nutrition. Then yes, I absolutely have done that.
Just to offer, Dr. Eric Vasquez from Cedars-Sinai is watching as well. And he offered and said, Dr. V, and he offered and said, commercial formulas are not SCD compliant. In the setting of someone on SCD flaring, I have used a switch to exclusive eternal nutrition for 2 to 4 months to reinduce, reinduce remission, then transition back to strict SCD.
Yeah, so just recognizing that I don't think, unless there's something that you could offer, Jeffrey, but I don't think there are any elemental diets that are truly SCD legal at this time.
No.
So you definitely would have to recognize that you are deviating from the plan. And again, elemental diet is not something that I recommend for patients to do on their own.
Okay. Well, one of the things that I'm aware of is Seattle Children's was doing a research project on doing a nutritional drink.
Mm-hmm.
Do you have any status on where that may be?
I think I might have seen something with the research coming up. Maybe Ollie, Dr. Arjumon gave it to me, but there was something about like trying to mimic an elemental diet with food and pureed food. I know they were talking about that at one of their nutrition symposiums 2 years ago. So I knew it was in process, but I don't know if it's completed yet. But it definitely would not be truly elemental. It might be more like semi-elemental, because elemental is down to, it has to be like, powdered food in its tiniest little molecules, instead of still having any of the cellulose or plant fiber or things like that in there. So I'll be interested to see, but it would be nice if we could do food. And I know that there are other plans that recommend a pureed diet for periods of time to help to induce remission. But yeah, I haven't necessarily seen the studies of food-based bowel rest versus elemental yet.
Yeah, this is Ali. That's right. Just to jump in, the evidence now is showing that a polymeric formula, that means it's not necessarily elemental down to the individual amino acids, for example, or carbohydrates, but a polymeric, which is kind of a mixed combination with some intact proteins, intact macromolecules, is as effective as a purely elemental diet. So that's kind of opened the doorway to creating basically your own at home, in your kitchen, polymeric food formulas that avoid having the emulsifiers, the high sugars, and any other component that is probably just bad anyway, and obviously non-compliant with SCD. So it's kind of a home run if we can get there. So it becomes a matter of commitment and tolerance, taste-wise. Can you like it? Can you enjoy it? And it's an ongoing effort right this minute, but I think a lot of good stuff should be coming out in the next 3 to 6 months.
Yeah, we want options, right? You want options. And for people, a lot of the elemental diet powders are extraordinarily expensive. So if we can do it through food, or if we can do it through other options, then that would be great.
Thank you, Dr. Bowen. So grateful for this time learning from you. What is the best approach to challenge foods you have been tolerant of on SCD when questioning a possible shift in microbiome, such as C. diff, infection, illness, puberty, etc.?
The best approach to challenge foods, do they mean that we've been intolerant to? Because if we're doing a food challenge, it would be a reintroduction. Is that what they're asking? But basically, if I'm saying reintroduction, then reintroduction of foods, typically if somebody's concerned about it, then we might even wipe a little bit of the food on our inner wrist before we go to bed and see if you develop a skin rash. So that might be one way to introduce it without putting it back in your body. And then if you pass that test, then you try one new food every 2 to 3 days to give your body time to react to it or not. And then when we look at some of those challenges like shift in microbiome, C. diff, illness, puberty, all of those things. Yes, all of those things can really impact the gut microbiome. And C. diff is a really nasty infection if anybody has had the misfortune of having it. And it does leave your gut kind of devastated. And when we talk about things like post-infectious IBS, SCD is one of my favorite treatments for post-infectious IBS. So you're already on the right track there. But then do you need to introduce probiotics or fermented foods or other things to be able to really help the body normalize? And then things like puberty, hormones have a huge impact on the gut. We didn't even have time to scratch the surface on that topic. But hormones have an impact on the gut, and the gut has an impact on hormones. And so that could be a whole other can of worms as far as, where we should go with that particular patient's case.
No, I try to bring that out. The hormones do have a direct impact. Maybe they'll become a subspecialty in gastroenterology one day.
Yeah, it's a two-way street.
Well, what's your views on alkaline water?
I have seen many people totally recover their health without the use of alkaline water. But then there are a few people who are really avid proponents of alkaline water. I've had some patients try to sell me some systems, but I feel like I take it with a grain of salt and just try to do general health instead of saying you have to have this system that only a fraction of the population could afford. Like, I do keep an eye on budget when it comes to those sort of access issues.
And last question, Dr. Bowen, if a 17-year-old boy has a very small appetite, not gaining weight, most likely because of insufficient calories, would you think there would be a GI problem making his appetite low? No symptoms at all except low appetite.
Yeah, it just depends on what the other diagnosis or testing has revealed. And so do rule out IBD if it hasn't been ruled out already. Make sure that there aren't other things on board like ADHD medications. Those can really reduce appetite. And then also making sure that he's okay, right? People will oftentimes lose their appetite when they've lost their appetite for life, or they're not excited about things going on. That appetite can really mirror people's mental health. So that's definitely something to consider, but rule out other things going on for sure.
Can we talk about the effect of a colonoscopy prep on the gut microbiome? How long can it take to recover? And should we be doing anything different or modifications to SCD?
So a gut prep is not going to do, even though it feels like you've lost everything that was inside of you, a gut prep is not necessarily going to devastate the microbiome like alcohol would. And so, or antibiotics. And so it's important to know that you still have your microbiome intact. You just got a real bad clean out. And so the clean out can feel aggressive to the microbiome, but the microbiome is going to survive that just fine. But getting back to, again, as diverse of a diet as possible, as broad of a diet as possible, 30 vegetables a week, if you can do that, and then fermented foods if you're able to.
Okay. Thank you so much, Dr. Bowen. You have a whole day ahead of you, and but we do appreciate your time. There were some more questions. We will follow up with you separately so that you might have a chance to answer.
Yeah, I would be happy to.
I will make sure that the resources that she talked about are sent out to all of the attendees that signed up. And I will also make sure it's available on the website. Thank you so very much.
Thank you. It was a pleasure. Bye, everybody.